This conference will now be recorded.
Good evening, everyone. This is Len Sierra for the high-risk recurrent advanced NCCN video chat for October 25th, Tuesday. And we're going to start off with an update from Dennis McGuire. So Dennis, the floor is yours.
Hi, everyone. Hopefully my microphone is working. My camera is not. Can everybody hear me?
Yeah, we hear you clearly.
All right, great. So here's an update after my 6 Pluvicto treatments, which ended in August. So just a little background. I had a great response from Pluvicto. My PSA went from 300 down to 2 over the course of 10 months. But I'm starting to see an increase. So 8 weeks after my last treatment, my PSA is now 4.7. So for me, Pluvicto works when I'm being treated, but it doesn't have a lot of durability. That's my interpretation so far. Obviously, we'll continue to watch the PSA. I'm scheduled for a PSMA-PET scan next week, just to get an update on the status of the lesions. When I started Pluvicto, I did have quite a few lesions in the lymph nodes. And my docs right now are recommending abiraterone. With the goal that potentially we could re-challenge with an anti-androgen. So that's the update.
All right, I think I don't know, Herb, you want to start off because you're in a similar spot to Dennis.
Jump in and say, so Dennis, I guess I'm having the same issues, but I'm behind you. So my latest PSA is now down to like 1.07. So it dropped by half a point in the last 3 weeks, which I always thought was good. But I think the durability issue of Pluvicto was real. And the question is what to do next. You know, given you shared your numbers with us privately in terms of anemia and stuff. It seems like, you know, cabazitaxel, any chemo is out. So what if and then last week we heard from Ken about BAT. And I'm wondering whether BAT might be something to consider.
I was thinking the same thing.
Yeah, I have talked to Ken about it, and I've talked to another guy that some of us know who's had a fantastic response to BAT. I'm uncertain. I just don't know. I don't know enough about it. I don't know if I'm at a place where I should give it a try or if I should go with approved therapies first and see where it takes me. I might be a little more concerned if my PSA were significantly higher.
Right.
And I guess I'm going to withhold kind of final decision until I see this PET scans.
So,
For me, that's the real measure. PSA is a number. For me, it's really managing, you know, the lesions and the spread of the disease.
right. So you had not had Abby before, correct?
I have not had Abby. I did extend about 15 months after docetaxel.
Mm-hmm.
I got about 15 months out of docetaxel and about 2 years out of extend.
Dennis, the statistics on Abby following enzalutamide aren't very good. I think the odds are something like only maybe 15% have a response, and it's not very long-lived, maybe just a couple of months. But as you say, your PSA is low. If you want to exhaust the approved indications,
Yeah.
I guess that's the way to go. If it doesn't work out, then you can have a discussion about BAT. Oh, what I wanted to ask was, when they do the PSMA scan, the next one, will they also do another scan to check for concordance or discordance?
That's a good question. I don't know. I don't know if we're going to
At
do
this
it.
point, my guess is that they won't, just because he's already had the treatment and it worked.
Oh yeah, there's no question it'll work against the PSMA positive lesions, but he may have exhausted most of those
Right.
lesions. It could be that what's causing the rise now are non-PSMA
Right.
active
Right.
lesions.
So, I would suggest that they do this concurrence. I mean, I'm just been talking to Mike Yancey or writing with Mike Yancey, and it's not clear whether they did concurrence for him, and he may have a couple of spots. I mean, he'll probably tell us a little bit later, but he may have a couple of spots. And if we know that there are spots that are not avid, then it invokes a different treatment strategy. Not to say that the Pluvicto didn't work, but it might explain what's going on. So the first thing I'd say is the concurrence is always a good thing to do. And frankly, if I were a payer right now, I'd insist on concurrence, because I think if you're not concurrent, then you've got to carefully think about whether Pluvicto is the right treatment for you. Second thing I wanted to say is that I think the number is 8%, Len, of the people that had a response from abiraterone after enzalutamide. I mean, it was so long ago, but I think the number's 8%.
Yeah, I wouldn't argue that.
The next thing I wanted to talk about is who are the docs that are recommending abiraterone to you, Dennis?
Yeah, they're my docs at Wisconsin and Chicago.
I mean, to me, the best expert on this would be Mike Morris. Have you run it past him yet or not?
I have not. I haven't talked to Dr. Morris in over a year, since I started Pluvicto, and he's not actually doing out-of-state patients. So, I mean, he doesn't do phone calls or video calls. So I guess I would have to schedule a trip to New York.
Well, what about just, I mean, he's treated you for so long, I'm sure he's going to respond to an email. And he may talk to you. I mean, you're an old patient.
Yeah. Yeah.
And frankly, you know, he's probably one of the best experts on Pluvicto in this country. And he may well know more about what's going on with rechallenging on Pluvicto, and he's going to have a creative idea as to what to follow with. And I think if it were me and I had a relationship with Dr. Morris, it's not like we're sending you to Dr. Morris as a new patient. I would definitely reach out to him and worry
This may
about how
be
you.
a tax call, Rick.
I'm talking,
This,
Jeff.
he would have to file taxes in each
Martin,
state.
I am talking, man.
Yeah, I
Who
know,
are
but
you?
this is
Well,
this is
wait
a
a minute.
tax issue,
Well, wait
possibly.
a minute, or I'm going to kick you out, Jeff Marchi. Don't do that. I'm sorry, gents. It's just rude to break in on somebody in the middle of a sentence. It's unacceptable. Now, we'll come to you. I promise. What I'm saying is, you're an existing patient. You can send him a note and let him choose the method of communication. I can't imagine he won't respond to you, and he has more knowledge probably than all the other doctors put together when it comes purely to Pluvicto. That's what I would say, Dennis.
Yeah, that's point well taken. I will reach out to Dr. Morris.
Okay, Jeff Marchi, you wanted to say something.
Yeah, if he takes patients in other states, he has to pay taxes in those states. There are lots of implications in doing that. It's expensive. And I suspect that's why he is not willing to take patients unless they physically come in, if they're out of state.
Well, but
He is,
Jeff, if he doesn't bill, there's no tax issue.
that's right. And he's an existing patient. He's been with Dennis for years. And just out of courtesy, he's going to offer an opinion. Dennis is not going to him and saying, I want to be your patient. He's asking him for just for his opinion. That's all.
I understand, but it's if he had 20 people calling and the amount of time it would take, I mean, it's his call, obviously.
So Mike Yancey, I think Rick was saying that you might want to weigh in on this.
Yeah, basically, Len, just kind of, I was going to give a quick update also since we're talking about Pluvicto, but just to give my background a little bit and kind of bring everybody up to date. Of course, it's been determined that my cancer does not put out much in the way of PSA. Before I started Pluvicto, PSA was at 0.99, that is, and then it jumped to 1.3 after my first dose of Pluvicto, but after my second dose, it's now down to 0.66. That's a couple of weeks after my second dose. So it has dropped what little I do put out. Now, I did have scans this week to see how Pluvicto was working. And it did show that I had some reduced uptake of the cancer in my shoulders, my clavicle, my pelvis area. And so it seemed to be reducing some of the cells there, cancer cells there. But in my intact, since I have my whole prostate still taken out, even though it had a high HV at the initial scan, it has had no impact on my prostate itself. And the other thing we found is that, well, first of all, I have asked for, and I've been working with Rick on this, for a reread of the elusive scans. So I'm hoping to get that done, just because I'd like a little bit more detail on what we saw. Talked to an oncologist today, and he admits they outsourced their reading of those. So I think I can get more detail from Teralex or whatever you say it. Now, one other thing that in my particular case that I've been dealing with this week is I've been having increasing back pain since right after first Pluvicto, and originally thought it was muscular because I'd gotten out and done some heavy work, etc. But it continued for several weeks. Discussed it with the oncologist. He gave me some muscle relaxers, did nothing. And so at the same time we did the scans this past week, we also did a CT scan to see if we could determine what was causing my back pain. And what we found is that I've got a very large growing cancer lesion on T9, T10 that does not put out PSMA. So therefore, Pluvicto is not having any
I'd like to
thing to do
thank
with that.
you for inviting me to speak once again.
But what we found was that it's pressing on my spinal cord, and immediately they were very, very concerned because I've already got numbness around my side and stomach. And they were concerned that I was going to end up with incontinence, loss of bowel control, or potentially even become a paraplegic with it. So they got right on it. I've already started radiation to try to reduce that thing. I did also have some concerns about, with my 3 bad mutations, P10 loss, RB1, TP53, that it might already be mutated into neuroendocrine. And the good news is that at this point in time, that is not the case. So that's kind of where I'm at. I got my 3rd Pluvicto infusion scheduled for November 3rd. That's my update.
Okay, so I want to come in maybe and talk about this a little, but I wasn't actually done with some comments for Dennis. Dennis, when was the last time you had next generation sequencing done?
Yeah, it was a year ago, October of 21.
So again, I think it would be a good idea to see if there's anything new that came up, because this cancer is changing all the time, and it might be that it throws out a lead. I'm assuming that you were not MSI high when you did the last NGS, is that right?
MSI stable.
Right. So, maybe that's changed because it can, and maybe there's something else. So I don't think there's a downside to getting sequencing. The other thing I wanted to say about BAT, and Len just posted something for us that PCF wrote, and I haven't read it through, that there is there's some synergy between BAT and towards the latter end and immunotherapy, and maybe Len will talk about that a little later. I haven't read it yet, but the one thing we do know I think with BAT is it is, in best case, it's a hold. It's an 8 to 12 month. So in figuring out whatever's going on, if you think about BAT, the expectation should be about 8 to 12 months from BAT. Do the other moderators have any?
Well, Rick, I'm just reading a much longer, I just published a paper in JCI, which I'm in the middle of reading. But depending on molecular markers, it could be longer than that, depending on your particular status of androgen receptor positivity and such. It could be longer than that, and they've stratified. So, but on the other hand, what we just heard from Dennis is Pluvicto is just buying us 8 to 12 months, and we're touting Pluvicto.
Well, I think we're talking about an average here. And with Pluvicto, we kind of know it's 12 to 24 months. We've known that for a long time. I mean, that's really what the 18 months, 24 months, that's the Pluvicto lifespan. That's its durability. With BAT, I've only ever seen, and I've only ever read 8 to 12 months, even in that paper that summary paper that Antanarakis and Denmead and Markowitz published just recently. I don't know if that's the one you're reading, but from there they're saying
this is newer.
This is newer. So maybe if you have certain markers, yeah, you could get more out of it. But I think, for Joe Smith off the street, that should be the average expectation. And for some people, it's going to be much better. And for some people, it's going to be worse.
Right. But I'm thinking in Dennis's case, remember, Dennis is like me in a way. I'm heading towards anemia from Pluvicto, and that eliminates some therapies. Whereas I don't think I think BAT actually could be successful and not provoke anemia. Abiraterone can provoke anemia sometimes. So I'm just thinking along those lines, Rick. But I mean, I agree with you 100%. I think sequencing right now, either a liquid biopsy or if they could do a real biopsy would be optimal. Because then we get to know what the molecular characteristics of what you got. So especially if it turns out to be that there's some non-PSA sensitivity, there are other techniques.
Are there
Dennis,
any
where do you live? Dennis, where do you live?
Milwaukee, Wisconsin.
You know, if it was me, it might be worth calling up and taking a drive over to Minneapolis and having a consult with Dr. Antanarakis and seeing if, you know, BAT is really realistic in your situation or not. I mean, it's not that far a drive away.
Yeah, was he involved with Den Mead in the bat?
Yes,
Yes.
he has been an author on papers on BAT.
I just talked to him yesterday and he said he can do it here.
Okay. Thank you, Peter. It's a good idea.
He knows us really well. And you know, if you want to get in to see him, one of us can send him a note. Peter can send him a note. We've got enough people. Joel can send him a note. We've got so many people that he really knows well and likes. And so, you know, we have good cred with Dr. A.
I think that's a great idea.
I mean, it's certainly a possibility. But all that said, I definitely would still get Dr. Morris's opinion, because he may, you know, he knows what they're doing in Australia. He's hearing stuff around Pluvicto that a lot of the other docs aren't hearing, because he's deep in as a PI. And so, you know, he may just have a tip, and he knows Lang and he knows Antanarakis. I forget, who's the name of the guy? You have a younger guy at Chicago, right? I can't remember his name.
Yeah, Dr. Patnaik.
Patniak, that's right. But you know, he's certainly going to know. He's certainly going to know Antanarakis and Lang pretty well. So you know, so it's easy for them to have a conversation with him if he has some creative ideas.
Has anybody had a rib biopsy? Is it doable, tolerable?
It's doable.
I was just thinking about maybe some tissue for that resequencing on that oddball lesion that doesn't express PSMA.
You're talking about for Mike Yancey now, or for Dennis?
I thought I was talking about Dennis, unless I've got my signals crossed. Did I get my signals crossed? Is it Mike that has the non-PSMA rib lesion?
Yeah.
Oh,
yeah.
Okay. Sorry about that. We'll get to that later.
Yeah, we'll come back to Mike, and I want to put. I'll give you some thoughts on that rib lesion in a second. But anyway, Dennis, you know, I think you've got some action items. One is one way or the other to try and get some biopsy done, or a liquid a next generation sequencing done. Secondly, to seek some opinions, including, you know, maybe Morris and Antanarakis, as to what your next step should be. And then, you know, you'll come back to us and you'll tell us where you stand. And like you say, at least we're talking now from 4.7 and not 300, right?
Yeah. Yeah, it's definitely a better place than I was.
Right.
So I wonder, is there any harm in starting Abby, or should I put that on hold?
I mean, if it were me, I'd want to hear back from Morris first, and it's really up to you as to, you know, whether you want to become a new patient for Antanarakis and get his feedback.
Yeah.
Because with
Yeah,
Antanarakis, you are going to have to become a new patient.
Yeah, I guess I'm just kind of thinking out loud. I guess the risk of starting Abby would be if I did something else, I'd have to have a washout period, which could be as long as 30 days.
Right.
So maybe I should be patient and not start until I have more opinions.
Yeah,
I think I would do that.
Yeah, you're right. Because with Abby, how long does that? What's the half-life on Abby? Anybody?
Well, I mean, it could be, there's still a washout period. It's half-life of the drug is not quite the same because remember, it's an irreversible inhibitor of the enzyme. So that means you have to, the half-life is really determined by how long it takes to resynthesize the enzyme. And that could be a while.
Right, and then you got the prednisone issue also.
Right, and then you got prednisone.
Right.
All right, well, lots to think about. I will pursue those action items. Appreciate your comments.
How's Lynn doing?
All right, thank you.
How's Lynn doing, Dennis? Before you go, have you been in touch with her this last week? Is she okay?
Yeah, moving forward,
Okay.
as well as can be expected.
Okay. Okay. We'll give her our best. Send her my love, and hopefully we'll see her in the Care Partners group.
All right, thanks for that, Rick.
All right, thanks, Dennis. I'm sure we'll be hearing from you after you talk to Antanarakis. Alan Babcock, I think you were one of the first ones.
Len, we got to go back to Mike Yancey.
Oh, okay, yeah, Mike. Go ahead, Mike.
So one thing I wanted to say about the ribs, if you have a lesion towards the back of your ribs, it is biopsiable. So, you know, where the ribs sort of become very bony around the back, if the lesion is on the front of the ribs, on the skinny part of the ribs, it's very, very difficult to biopsy it. We've generally heard that it's not biopsiable, but where we have heard it can be biopsied is if it's towards the dorsal side of the ribs.
Yeah, it was actually on the spine, and we actually got a lot of tissue off of it yesterday. So, yep.
Yeah. So, you know, Mike, as you know, in going back and forth, I think it's, especially if you're going to do another PSMA scan, I think it'd be really important to be looking as to whether it's concurrent or not. With the
Yeah, and that's an area that's confused, Rick, because I know we didn't do an FDG, but as I've tried to study and ask and get educated, it seems like sometimes there's references to, I'm going to use the term CT scan, that also are used as concordance. I don't know if that's accurate or not.
So there are two. So they always do a CT scan with a PSMA scan so that they can locate the scan anatomically. But it's not an FDG scan, so it doesn't pick up the lesions. The CT scan that's done with the PSMA is purely for geography. At least that's my understanding.
I hear what you're saying. That's where I've asked.
Right, and what we need is, and it was really the Australians that pushed this home about a year and a half, 2 years ago. that they feel strongly that you should be doing concurrence to see what lesions we can see, and then if at least the lesions we see on a regular FDG scan show up as being PSMA avid. Because if you've got lesions that we see on the FDG that are not PSMA avid, we know we're not going to get rid of them with a PSMA radionuclide treatment.
Yeah, and all I can say is that when I've asked specifically about that CT scan, once again, without getting into probably a lot of very much detail, I have been told that what they do with what they refer to as that CT is they can see non-PSMA lesions. So that's all I know.
So I think, I think that's one thing. I think a second thing is to have some discussions about treating the primary at some point.
Yes.
And I mean, and I don't know that we've ever had anybody go through Pluvicto who had a gland that hadn't been treated. So I don't have any experience. I don't know if any of the other moderators are aware of situations where somebody went through and they had an untreated prostate gland. So I don't know what I don't know what the lutetium, how the lutetium responds to the primary. Just have no experience. But I think that those are probably the next two things. I mean, you've done how many sessions now of Pluvicto?
2. I do my 3rd one next week.
And your PSA is, it went up after the first one and down after the second one, right?
That is correct.
But your concern is that you think that you have some lesions that are not avid.
Correct.
Right.
At least one, we have identified one lesion on my spine that is not avid, which is the one I had the biopsy on yesterday.
Okay. And so, and how do you know it's not avid?
My answer to you is going to be because it was picked up on the CT portion and not the PSMA portion of the scan, as I understand.
Got it. Okay, got it. Perfect. Okay. So I think that whoever is directing your treatment, you have to you got to huddle with them and find out whether Pluvicto is the right way to continue with you, or whether you need to think about a different type of treatment.
Yeah, I'm gonna give it more time before I make a change. At least probably two more infusions before I decide whether to change horses or not.
Okay. What about the other guys? What do you think?
Yeah, if you don't mind sharing, how are your blood counts holding up? Your hemoglobin?
They're holding up excellent. I mean, yeah, my blood counts are doing great. I'm doing fantastic from that perspective. In fact, there's very little change from analysis from lab to lab, to be quite honest. They've actually improved in some cases, yes.
I think from my experience, that's an area that guys need to keep an eye on as they go through Pluvicto.
Right.
Mike, have you had chemo yet?
Yeah, I had chemo back. I finished up November 29th last year. I had docetaxel at that point, and then I started Abby in April of this year.
Okay. Any other questions for Mike, guys? Or Mike, anything else you have for us, or should we move on?
Oh, I thank you for your comments. Thank you for your time.
Okay, thank you. All right, Alan Babcock, you're up.
All right, so just a bit of an update and let you know what's going on. I'm 4 weeks into radiation, salvage radiation treatment, and I've become incontinent big time, which really makes doing the radiation a bear. I started using a penile clamp, and that seems to be working, so I can do the radiation treatments. And I use it during the day at school, so that I can go to appointments and don't have to leave in the middle of appointments on most occasions. And then I come at home and I take it off and just use a maxi pad, the maximum pad, because I'm just leaking all over the place. I just I just didn't expect this to be so incontinent, but yeah, I can hold it in a little bit by using a Kegel, enough to walk to the bathroom, but that's the best. And I'm working my ass off, to keep from urinating. So that's where I am. I'm done the radiation on November 15th, and we'll see how well I recover. I think on Monday night, my wife saw some blood in my urine because she took a look at my pad and it was brown. She said, "Ma, you got to tell somebody at the hospital, at the cancer center, that you have blood in your urine," but we didn't have any today, so that's a good thing. So I just, the pad, I didn't realize the clamp was going to be so useful. It's just like, okay, and it's not painful for me. It's like, okay, this is a very nice thing to have because I'm not peeing all over the place. So that's all. Just, if anybody has any questions or any comments, but that's where I am right now. Not real happy about being so incontinent, and I sure hope I recover after the radiation.
Well, Alan, did you have incontinence before you started radiation?
I was just about ready to get rid of my thin pad. After the prostatectomy, and I did Kegels before prostatectomy and after prostatectomy, and so I was just ready to get rid of my pad, although they pointed out to me I was partly controlling my incontinence by not drinking much water, which was a big problem. I was dehydrated at the beginning of the radiation treatment, so I'm not so sure I was as continent as I thought that I was, but from my point of view, yeah, I was in great shape before I started the radiation treatment.
Because I know the conventional wisdom years ago was if you had some degree of incontinence before starting radiation therapy, then you kind of locked it in. I don't know if that's changed. Does anybody know if that's changed?
They asked me about that. And I told them, no, I was good. And the doc said, good, because that's where that's not going to get any better. But it got a whole lot worse.
Okay. What type of radiation are you getting?
That I can't tell you. It's on his notes. I'm not.
Is it HDR brachytherapy?
No, I don't think so.
Because you tend to get more urinary problems with that type of radiation.
All right. With the brachy, I get more. I'll check that out. I'll go on and take a look at his notes.
Are you going every day?
5 days a week. Yep.
It might be IMRT.
And 37 treatments.
IMRT.
Yeah. Definitely IMRT. Okay.
That sounds right too. I think I saw that when I read through the notes.
Alan, have you done the pelvic floor rehab?
No, I've just done the Kegels.
Look into the pelvic floor rehab. It helped me a lot. It's a special physical therapist that does it.
Mm-hmm.
You get the finger up your ass again. That's kind of nice.
Oh yeah. Hey, I have so I had trouble cleaning out my ass. I get a fleet enema every fucking day. Every day I do it. I mean, I'm taking so many laxatives, and milk of magnesia, laxative, and some other, and milk of magnesia, and Miralax twice a day. And I don't have any solid. I haven't had solid bowel movements for a month, so that's no fun. But the worst part is the fleet enema every friggin' morning when I wake up. But
I don't know what this is worth, Alan, but I was told, just like Len said, this was in 2020, February when I had IMRT radiation. Before it, they told me very clearly that your incontinence is going to stay where it is, or not, at least not get any better. If not, they didn't say it might get worse. They said it wouldn't get any better once radiation began, just like Glenn said. So I think that's still kind of the conventional wisdom there. But they also told me, even I had a problem at the beginning with the bowel being completely clear too, and that I took enema, and they made it very clear to me that they didn't think that that was a good idea to do too often. So I'm surprised that you're doing it every day. I'm not saying it's wrong. I'm saying that they cautioned me not to take an enema that often. I don't remember why, but that was what they told me. But as far as the clamp, you may enjoy the clamp for a while. I would gamble that you're not going to enjoy it long term, but as you know, there are other solutions if you don't.
Yeah.
And if you
Yeah,
do,
right.
it's great.
So what you're saying that my incontinence I have now is what I'm going to stuck with, or the incontinence I had when I started radiation? Because I can live with the incontinence I
Yeah,
had.
I haven't heard of it getting worse after radiation begins, so that could be, that's not something I'm familiar with. So that's just what they told me. And everybody's different, and you may, you want to make every effort you can to recover it through the
Yeah.
Kegels, the pelvic floor, and everything else. But as you know by now, sometimes it works and sometimes it doesn't.
Yeah.
Have
Yeah,
they checked
I
your
really-
bladder?
If it
Have
sticks
they
around, I'm
checked your?
going to have to get a artificial sphincter in there.
And I have one, and I can't recommend it more highly if you can't solve it.
Right. All right.
You can
Well,
get a
that's good.
sling as well. They have a sling that they can put in the office.
Yeah, I got to interrupt on
can
that.
stop
because,
it.
Jeff, the sling does not work for relentless incontinence. If it is the final frontier, and some people try a sling and it doesn't work, so the sling is kind of the stop before the AUS. And sometimes
I'm
it
wondering.
works, it doesn't.
I'm wondering if they actually checked how full your bladder was when you were having your radiation the first few times, because that is absolutely critical that you have drunk enough water, that your bladder is full to a certain point. And if they're not checking that, then the radiation might be hitting the wrong spot. Now, are you familiar with that issue?
Yeah, they're checking it every time, and Dr. McHugh showed me the scans one time because I had a lot of questions about it, like how do you know how full my bladder is? How do you know? And he said, "Here, let me show you." And so he called it up on the screen. Yeah, they check it every time, and once in a while they'll send me back to the waiting room. Now drink more water.
No.
Now I'm up to 50 ounces before treatment, so that hasn't happened in like 2 weeks. But at the beginning, I was concerned because, all right, it's good enough to do the radiation. It's not where we want it, but like your bladder's 80% full and your bowel's kind of emptied. And I even asked Misha, I said, okay, I'm worried about what the hell's this doing. He said, it's okay right now, but yeah, we got to get in better shape. And after the first week, after all those laxatives and enemas and all that shit, then I was good. I was always 90, 95% full. So I think I'm okay that way. That's what they're telling me.
I just would be concerned they're hitting the wrong spot. I had 6 weeks or so of radiation and never had any incontinence problems during it. And it's surprising that yours would be so extreme so quickly if they're hitting the right spots.
Well, I'm going to, Dr. McHugh is at a conference this week. I'm going to have another physician there, so I may ask him about that. I will ask him about that.
The other thing that I'm confused about is doing a fleet enema every day. I never did a fleet enema every day when I went through IMRT. I mean, how about I just like to ask other people who have done IMRT to the pelvic girdle, did you have to do a fleet enema every day?
Never.
Never. I don't know where I don't know where that one's coming from, Alan.
But it was because I wasn't getting my bowels were not emptying. So he kept upping the ante. Like that was the final frontier, if you will. That's the final thing he recommended.
Even with the Miralax, what was your diet like?
They have me on a low residue diet. So I'm eating like white bread and pasta. I looked up that whole diet, and my wife is, as well as she can, got me on a low residue diet.
I have to say this, Alan. They put me on the same diet, and I had constipation, even with the Miralax, and I told them, I want to go back to my regular diet. And they said, if you leave the kale out, you can go back. So minus the kale, I went back to my regular diet and I had no problems. I could not adjust to having that low fiber diet.
Well, I've got the worst diarrhea. I mean, that's all I have. I get up in the middle of the night and you go to
Hello,
pee
Rodolfo.
and diarrhea.
Yes.
Alan and Rick,
Okay.
in the last, I had 39 treatments, and I also had the same problems emptying my bowel for about most of the last 2 weeks. I finally resorted to a Fleet's enema before I went in every day, and I told them what I was doing, and they said that was all right if it was working. So it was less than 2 weeks, but almost that long.
Dr. McHugh did say, well, maybe you could cut back to every other day. And actually, my wife vetoed that. She said, we got something that's working. I don't, but now I'm going to go ask about getting the enema every day and what the problems with that is. You know?
I'm sorry, Alan. How can you having diarrhea at night, but then you can't empty your bowel in the morning? Is that the idea?
So I have diarrhea all the time. And no, with the diarrhea, I am able to get my bowel emptied.
So why the enema?
Well, so the first week was a disaster, all right? And that's when each time they kept upping the ante. Then we got to the point where I was taking laxative, Miralax twice a day.
Okay.
And there was, there was one other thing.
Senna?
I took Milkamite to those 3 things, and it still wasn't quite working. And that's when he threw in the Fleet enema. Once he did that, yeah, I had diarrhea, but at least my bowel was empty. And that sounded awfully good to me because I was really concerned about having stool in my bowel and getting the wrong area radiated. So now we have something where, I go in, yep, you're good. Yep, you're good. You got it. Yep, empty bowel, full bladder. It's like I'm really not wanting to change too much unless I'm doing something that's going to hurt me.
That's temporary.
Have you tried adding Senna to your drugs for constipation? When I had my knee done, they had me take Miralax and Senna because of having to take opioids, and it really helped relieve the issues.
The Senna is the laxative that I'm taking?
Senna as well is a laxative as well as Miralax.
No,
I was taking 3 different things. Senna's pretty, it doesn't affect your body hardly at all, but it does increase your ability to move day.
My last question, Alan, is how much exercise are you getting?
A whole lot. I rock climb twice a week, and I probably, my wife and I walk almost, unless I have a meeting, I walk every night.
Okay.
And my strength is right there. I mean, I have not lost anything with my rock climbing. I'm right up to where I've been. So that's been good. And I have a friend who's going through all this, and he has to take a nap in the afternoon. I don't happen to take naps.
How many more treatments do you have left?
15.
You're almost there.
Halfway. Yeah, a little more than halfway. So I'm hoping that, I go through it. It's working now. I'm real hesitant to back off. And then hopefully I'm going to recover. That's kind of what, I think I read it somewhere. It said, okay, 2 to 8 weeks, you'll recover back to where you were pre-radiation. Now you guys have me a little bit anxious about that, but I will ask. And I'm going to be damn disappointed if this doesn't really knock the heck, out of the cancer. And also I'm on hormone therapy too. So now I'm going to have to wait 6 months before I find out really if this all worked.
It sounds like the laxatives got you going, so I can't see why you'd be. I don't see why you'd be subjecting yourself to an enema every day. That sounds like just pain on top of pain.
Before the enema, all those laxatives weren't working, and that's why he added that. And I'll ask him about it though. And but he did already say go every other day, and it was my wife who's a nurse. She said, you got something working on. Why? Yeah, put up with it for another, 15 trials, and then it's over. And she's usually right. So But I'll ask. I mean, and especially because somebody said that, yeah, it's not good to do an enema every day. So I will ask the doctor about that.
Just a reminder, Alan, you probably know this.
They clamp is like, yeah, you're going to hate that pretty soon. And I can't have it on. I got to release it every hour. My penis starts hurting. But that's what I do. And I can go to school, just go in the bathroom, release it, move it to a different location. The problem I read, the guy was on it for, I think, 6 months. No, 6 years. And then it got to be a real problem. But, you know, if I have to do another treatment to get continent, though, so be it.
I wanted to remind you that it took me many before the PSA went down from it. So
Say that again?
It took me quite a few months after finishing my radiation before my PSA dropped.
Okay, yeah.
So don't be disappointed if it doesn't become undetectable right after you finish.
Yeah, and Dr. Gennisman said, you know, we're really going to know, Alan, after you're done your the hormone therapy. I mean, if the radiation now, he's got me on the hormone therapy for 6 months. So in March, I'll be done the hormone therapy. That's when he thinks we'll have some sort of answer. So,
Alan, what was your Gleason score?
To 8.
I think 6 months sounds a little short for the hormone therapy. What do you guys think? Rick, Herb, Peter? You're muted, Rick.
Yeah. I mean, typically, if you've got a Gleason 8, a 4+4 post biopsy, at least 18 months, if not 30 months, between 18 and 30. And, you know, I know you saw Gainesman beforehand. And I think, as I recall, we talked about that at the time. And I think I said to you, 6 months sounds a little short. I can only tell you that where the guys have not gotten enough, they're the ones that have had the issues with the recurrence. The guys that have been willing to stick through it for at least a minimum of 18 months have done real well. So I think
I'll see him in December. So I'll raise that issue. I did not remember that or write it down, or I was being too passive and let him say 6 months. But no, I'll raise that issue with him.
the studies suggest that if you're a Gleason 8 or higher, that you should be on 18 months plus. There are several studies and they're slightly different, but it would suggest 18 months plus.
All right, thanks.
Anyone else want to comment on that?
That's my understanding too.
Yeah, NCCN guidelines, that sounds familiar.
NCCN guidelines?
NCCN.
Yeah. Those are NCCN guidelines. I think for the AUA, they have yet to. They're just revising their recurrence. So I'm not sure what the old AUA guideline was, but I'm pretty certain that Dr. John's right that that's NCCN guidelines for a Gleason 8.
All right, good. No, thanks a lot. I'll probably send him a message tomorrow and say, hey, this is what I heard in the support group. Can you comment on it? And I'm certainly willing to go. If he told me 30 months, I'd say fine, 30 months. I mean, it's a drag, but so what? So thank you.
Okay,
There's
Alan.
a patient version of the NCCN guidelines that's available without paying anything.
Yeah.
You could check it out before you write to him.
Oh, okay. I will do that. But I might be able to get it through the university too. Well, I'll see. I'll do as much research as I can and before I write to him.
Keep an eye on the keep an eye on the chat. I'm going to see. I may have a link to it, Alan.
Okay, Jim Jeffries, I believe you were one of the first ones on and you needed time tonight, so go ahead.
Just a quickie. PSMA PET scan. I have a script for one, and there's the image providers. Does it make a difference if you're using a small image provider or a major cancer hospital? Is the protocol the same for the approach and the actual process of the exam?
Well,
So
the beginning is the same, right? They'll take the images, they'll inject you with the tracer. But then there's where the divergence is at the end, is not the beginning. The divergence is in who reads the scan. So a small place that doesn't do very many, they may not be as expert. A larger place that's been now doing this for a while may have radiologists who are quite good. And then it also, as Rick will point out, depending on the company that's making it, you may be able to get backup readout by their radiologist.
Mm-hmm.
So yes, I would argue that it does make a difference where you get your scan.
Yeah.
Okay.
So Jim, couple of questions. I mean, what I know you've been on a drug. Where's your PSA and what's your plan right now?
Well, the PSA is at a 0.20, so the PSA is down. But I've had some CT PET scans which had a lot of hot spots, and then I was diagnosed with sarcoidosis, and
Right.
It's been 2 years since I've really had a CT PET scan, and talking with my oncologist, we agreed that, and he wrote a script for the PSMA-PET to try to further highlight what's going on. So I was just thinking, who does the imaging? Does that make a difference? That was my.
Hold on, let me just interrupt. Are you still with Gainesman? Is this Gainesman who's writing the script?
He's a second opinion, yes, at Fox Chase.
Okay. Who's writing the script? Who's
Dr.
writing the script?
Mark Chernoff.
And is he a genitourinary medical oncologist?
No, but I've been with him since.
Okay, so let me just tell you. First of all, he doesn't get it because you're not going to get much of a result at 0.2. There's no point in doing a PSMA scan at 0.2. I doubt that Dr. Gainesman would write a script for you at this point. They may see something on a CT scan, but for you to go through a PSMA scan with a PSA of 0.2, you have less than 18% chance of seeing anything. It's and if you're going to a regular medical oncologist, these guys don't stay on top of the literature. They hear, oh, great, PSMA scans. Oh, this is the new thing. We'll prescribe, but they don't know the details, Jim. And so I think that if you made an appointment with Gainesman, he'd say, it's a great idea, but we've got to let your PSA rise a little bit more. And otherwise, we're not going to see anything. So my first suggestion to you is I wouldn't bother. Secondly, if you are going to get a PSMA scan, get it at Fox Chase where they're seeing loads of them. This guy does, your guy, with the greatest respect, has probably hardly ever seen any PSMA scans.
Okay.
If he had, he'd know not to do it. Now, they may do what Mike Yancey's people do, and they send it out to a reader, and we don't know what that reader has seen, how many they've seen. So you've got to be asking everybody. You've got to be asking, if you get a PSMA scan, how many have you read? It's perfectly fine to do that. I am in the midst of dealing with 2 of these companies, actually 3 of these companies. and I'm trying to get into the Association of Nuclear Medicine, the Society of Nuclear Medicine and Molecular Imaging. I'm trying to get their patient advocacy, because what we want is certification from the NMMI for people who are reading these scans, because the companies won't enforce it. They've come back and they don't want to enforce it. They say, no, it's got to be done by the society. So I'm pursuing that. So number 1.2 is too low. Number 2, if you've got suspicious lesions on the CT scan, then but your PSA is still very, very low, I
But
would
it's been
just
historically low, even when I got a
right,
Gleason 10. So
right, got it. I think that the way to go might be to think about getting a biopsy on those lesions. But does anybody know if you are a low PSA producer, is that correlated with PSMA?
Not that well.
no.
Not that well. So you could be a low PSA producer and you might see a result at a 0.2. Is that what you're saying, Herb? If
Yes,
you are
potentially. If you're a really low PSA producer and you're making PSMA, you may see it.
Okay.
And Rick, I would tell you, Gainesman wrote a script for me, and I had a 0.21 PSA, and he just said, "I just want to see it. I just, you know."
Okay.
Then I said, "Well, how about we let it go up?" Because like you had talked about that, and I said, "What about?" He said, "Not a chance." He said, "No, we're going to start treating you. I'm not sitting around waiting for it to get worse."
okay. I stand corrected, Jim Jeffries. I'm sorry. I mean,
No. That's good to know. I appreciate.
No, we didn't find anything on the scan either, by the way, Rick.
But you didn't see anything on the scan.
No.
No.
Plus,
I mean,
plus if Jim, do you have sarcoidosis, did you say?
Right. That was diagnosed when I had all these hot spots a couple years ago.
Yeah, so you probably have the confusion of trying to make sure that a sarcoid lesion is not a metastatic prostate cancer lesion. PSMA will make that distinction, but probably, I don't know if a regular CAT scan, if they can, I don't know if the pictures look a little different so they can tell or not. Do you know?
Yeah, that's what the thought is now, to just see if we can compare this to the baseline of the other CTs and, identify, locations.
Oh, yeah. You, by the way, I know this is an aside, but do you have an eye doctor?
I have an eye doctor, yes. And he's
Okay.
very much aware of the sarcoid.
Okay, thanks. Yeah.
Okay,
I
thank
think
you.
NCCN
Yes, sir.
has the sarcoidosis support group, right, Rick?
Yeah, no, Jim attends it.
Oh, okay.
I attended, yes. I saw that there's a change, so they're still meeting, correct, Rick?
Yes, but we are changing. We've got things going on, and we are changing. And so just all I can say right now is watch this space.
Stand by.
So okay, we're going to a different. We're going with a different partner very soon.
Okay.
But I don't think that will affect Kevin. So anyway, we shouldn't be talking about that in this group. But what we should be talking about is there value? Does Gainesman know that you have sarcoidosis?
Yeah. Yes, he knows that.
I think I would ask Gainesman what his opinion is about getting a PSMA scan right now. If this was coming from a GU med-onc like Gainesman, I would say, okay, he knows why he's doing it and what he's doing. When it's coming from somebody who is not that less familiar, and when we've seen those numbers, and we know that around 0.2, that there's about a 1 in 5 chance that they're going to see anything.
Okay.
So So on this same vein, this is kind of what I had in mind. So I had one on the 19th and it was negative, but my PSA in August was 0.1, but it had been on the rise, so probably a little higher by now. And I asked the doc, and this is the radonc, and I said, why we don't, PSA isn't high enough. He says, you're new enough. I just want to make sure that you don't have a single hot spot in your pelvic girdle that they missed that I can treat right away. So that.
So I guess they're more aggressively writing scripts for it, just as a precautionary.
Yeah, and mine got approved with no problem from Medicare.
Okay.
What about serial PSMA PET scans? Is Medicare covering multiple PSMA scans per year? Anybody know?
Yeah, we don't have
For
the
me or
experience yet. Has anybody had a second PSMA turned down?
I've had 3 in the past, within the past 12 months, and Medicaid paid for it.
But that was through TRICARE, Joel?
You're right. The first one was TRICARE. The other 2 were Medicare, but they were all within 12 months.
Well, thank you for the comments, gentlemen. I appreciate it, and I'll follow up accordingly. Thank you, Rick. And
All right, Joel, as long as you're talking, continue.
Yeah, I have, like my issue, I have a question on Medicare. My radiologist called me and said Medicare declined your paying for your DEXA scan. Is that normal? That's my question. I didn't expect that.
They only pay once every 2 years.
But I've never had a DEXA scan.
Oh, then it doesn't make sense to me.
No.
Nor me.
Something wrong there. Maybe it got coded wrong, but no way.
Because what happened is it sounded like a scam because they said, okay, well, if you want to pay for it, we'll get you 45% off today. So I did go ahead and pay for it. It was $250, but I paid 137, I think. And so I can still put in the claim to Medicare, correct?
Yes.
Yes.
Okay. Yeah, it must have been coded wrong. That's why I wanted to ask the question. Also had a CMP VA exam 3-4 days ago. I'll comment on that more in the vet group, but so it was done by VES, and they interviewed me, and they were training another doctor, so I got to listen in on the questions the doctors were asking me. But it was
Joel, excuse me for interrupting, but can you give us what these letters? We don't know what these letters stand for. CMP, VES. So, sorry.
Okay. Jim Marshall, can you help me with CMP and VES?
Oh, the VES, I believe, is a contractor. Okay, and I don't know exactly what they stand for, except it's a contractor.
Okay.
CMP is let's see, I believe is a compensation and pension exam.
Okay.
So that's all I had, Len.
Okay, thank you, Joel. Carl Foreman, you're up. Is Carl still with us?
He's muted, but he's on there. Carl.
Maybe he stepped away. Let's see. Let's go to Bob G while we're waiting for Carl.
Okay. So, so I had my 6th and hopefully final chemo yesterday. In 3 weeks, I'm going to retry abiraterone at half dose. I had to stop it right before chemo started because my bilirubin shot up, and they said that chemo's tough enough on the liver, and they were afraid liver damage if I kept going on abiraterone. The beginning of December, scans, and then I see the doc, and we see what's going forward. A couple questions or maybe comments. One thing that's happened is that my decrease in the PSA has pretty much plateaued. So at fourth chemo, I was 1.567, fifth, I was 1.108, and just yesterday it was 1.069. So it's barely moved now. I don't know if that's normal, and I know for a lot of people on this call, having a PSA around 1 would be great, but I'm just wondering, is that something that people have seen with that just over time chemo just stops lowering the PSA, or maybe I need to be the Abbey? And the other question I had is the scans they want to do are CTs and a bone scan because that's what I had 6 months ago. And I've made some calls to see about getting a PSMA scan, which the insurance will cover. And I got two prices. I'm just wondering if these sound like the right price, or I should keep calling. One was like 6,500 and change, and the other was 66 and change.
Mine was 20,000. At least that was the list price.
Okay. Yeah, I mean, I told them, insurance isn't covering, and both times they're like, let me get back to you, talk to the manager. And, one is an imaging center, and the other is where I go for treatment at Penn. So, but if 65,
Why,
66, I'm sorry?
why is the insurance not covering your PSMA scan, Bob?
What I was told by my doc is that they're either going to cover the CTs and bone scan or PSMA, but not both.
No, that's not right. It's not right because it's back to this concurrence issue, and they're covering it because they have to check concurrence. Because if you're eligible for Pluvicto,
well, I'm only 6 months into this. I'm not castrate resistant.
I understand, but they don't know that.
Okay.
They don't know that, and that they'll cover an FDG and a PSMA scan, just to determine if your lesions are avid or not avid.
Okay. So maybe what I need to do is get the PET or get the CTs and the bone scan, get those done and out of the way, and then have them go for authorization on the PSMA. Because it sounded like they can send in to get authorization for one or the other, but not both at the same time.
Well, I mean, I've never heard. Who is it that is Penn telling you that?
Yeah, it's Independence Blue Cross, which are a pain in the ass.
Okay.
As an insurance company.
I've not heard that before. Has anybody else ever had this issue?
All right, I will look into that. Yeah.
If your PSA is 1, why would you bother with the bone scan and the CT scan? Why not just do the PSMA scan instead of them?
Well, that's what I had when I got started 6 months ago. So they wanted to compare apples to apples.
Did you have anything on the bone scan?
Oh yeah, I have six spots.
Okay.
Bob, I've also had issues with independence.
Yeah, they're no fun to deal with. But yeah, I will definitely. Maybe I'll even try calling Independence. And I'm feeling good today because of the steroid. Tomorrow I'll probably be feeling pretty crappy. So I want mine to stay on hold for an hour.
Bob, I can tell you that I had to go get the scan. Swedish couldn't get a reimbursement agreement with Medicare, so I had to go to a different provider to get it. But I'm getting Pluvicto. It's Swedish, so all I know is that sometimes the provider and whoever your insurance company is, they can't agree on how much they're going to reimburse for.
Okay. So yeah, sounds like it's something worth pursuing rather than, just going ahead and paying $6,500 out of pocket.
It is really useful to compare apples to apples, as somebody said.
Yeah, and that's why they wanted to do that, because I have not had a PSMA, but I would like to get that because I know there's stuff that was not picked up on the CTs or the bone scan.
Oh, yeah, yeah.
So, okay. All right. Thank you.
How's your neuropathy doing?
The acupuncture seems to be helping. It really is. I don't know if it's helping all that much with the hot flashes, but Zyrtec, which I'm taking because I'm, doing a PEG, I'm doing Neulasta, that actually, I read that Zyrtec can help with hot flashes. So I'm going to continue on that past the 3-4 days from the Neulasta and see if that really does help. It's hard to say for sure because of the steroid, that I took the last 3 days, but the last one was this morning. Thanks for
Bob,
asking.
have you tried the Ember Wave for the hot flashes?
I have not. I mean, with the cooler weather, the hot flashes haven't been quite as bad. And the acupuncture, she's trying to see about working on that too. And it's hard to say if that's helped. The steroid, the dexamethasone, that tends to really make them worse. So I'll know better in a few days. But yeah, I'm familiar with that. Thanks.
Okay. All right. Thank you, Bob. Robert Glover, are you still with us?
Yeah, I'm still here.
Okay, you're
well, last time I was here and had time to talk was really my first time. I started out with originally a Gleason 7, a 4+3, sent the biopsy out to Johns Hopkins. They came back and they looked at it and they came back, said it was a Gleason 9 with a 4.4+5 on one core and Gleason 8 and 3 other cores, and all of the other cores were 6s and 7s. So originally the radiation oncologist wanted to do PSMA. Insurance denied it multiple times. Also Anthem Blue Cross. They decided it was not medically necessary. Fortunately, my new urologist pushed it through and appealed it and won, and so we did that. My urologist was concerned that the cancer had gone beyond the prostate because there was a couple lymph nodes flagged from a CT scan. PSMA did not show anything outside of the prostate. So surgery is back on the table, and that was a kind of a big change. I originally thought that it had gotten out, horses had left the barn, and I was going to jump right into radiation. And now that knowing that it's so far appears to be contained in the prostate, it seems surgery is a viable option as well. So that's the path I'm looking at. I didn't preface this. I hadn't had any treatment yet, so I am very early in my journey compared to most of the folks on the call. So I'm not really sure at this point. I've kind of scheduled the surgery to see. Hopefully that'll take care of it. So
Boy, I am
technology here. So
I am really interested in what our knowledgeable guys think of doing a prostatectomy with a Gleason 9. What do you guys think?
You got my opinion on that at lunch, John.
I think it's not, I really think you need to think about that. A Gleason 9 is a good aggressive cancer. And the idea that there aren't any micro lesions around is pretty slim. I mean, I'm sorry to say that. And so I think that you're going to put yourself through surgery, and it's, in the end, you're going to end up with other treatments that you're going to need where you could have done without the surgery. Why not radiation?
You know, Bob,
Yeah.
there's a nomogram. Do you know what a nomogram is? It's a,
Somebody mentioned it before. I went on the website and it said it wasn't available.
a nomogram wasn't available.
Yeah, it was like
Somebody just put in, Rick just put the link in.
Yeah, but
Okay.
you know, guys,
Hopkins has it. There's probably other ones. They supposedly will give you at least a guess on what the chances of getting a cure out of surgery are. You know, input things like your Gleason scores and other things.
I've heard
Okay, yeah.
with the NSK nomogram, I've heard that if you're Gleason 9, that you really shouldn't use it. It's not meant for someone that high risk.
Oh.
Anybody else hear that?
I had heard that, but I'm not sure. When you're a Gleason 9, it's pretty high risk. What is it going to tell you?
Yeah,
Right?
exactly.
It's going to tell you that surgical cure is not very unlikely.
Right. Or any cure.
Well, yeah, we don't want to. I mean, that's correct, Len, but surgery is torturing to people. Some people.
So let me comment on Len first. Len, I think that it may not be that helpful in the sense that it's always going to give you a low percentage, but I think that it's the only reason I can think it's not that useful is because there are very few people in the database with 9s and 10s. In which case that might be an issue with the database, but but that's because there are very few people with 9s and 10s that are doing surgery. Let me first explain to Rob what this nomogram is, in case you don't know. It is the experience of many people who went through surgery at Memorial Sloan Kettering as to what their outcomes were. And they document all of that. And then you can go in and you can see how you, with your disease demographics, compare to those people. So it's kind of a predictor, but it's nothing guaranteed. You just have to understand this is what happened to people similar to you.
Yeah, I don't know that I know the terminology well enough, because it says researchers can access the coefficients and model properties.
Yeah. I think you pressed on the wrong thing.
That was the link somebody put in the chat.
And I put the link in, and I do know. Okay, what you want to click in is not where it says click here. You want to click where it says pre-radical prostatectomy. You clicked in the wrong place.
Ah, okay.
Okay, Eureka.
Yes, the section header was clickable. I was clicking on the thing that looked clickable.
I know, because do you know why I know? To make you feel not so bad? Because I haven't clicked on here for a while, and I did the same thing myself yesterday because I was looking at it for somebody.
Because I think I came to that and I was like, I don't know what all these words mean, because it was the researcher one.
Right. Now, what you need to do is to fill in that information. So you need to put in you need to answer the questions. You haven't had any Lupron. You haven't gotten any radiation. So your age is simple enough. Your PSA right now is simple enough. Your primary Gleason is 4, and your secondary Gleason is 5, right? You were a 4 plus 5, not a 5 plus 4?
Correct.
Right. So you put in a 4, you put in a 5. what was the biopsy Gleason score? That actually will populate itself, if I remember right. Do you know your clinical tumor stage? Are you a T2B or a T3A, or what do they tell you?
I believe he said, I think he said it was a T3, but I don't remember a letter. A stage,
So
a
there
stage
will be a
3?
letter, it'll probably a T3A, but if now that they found nothing outside, they should be restaging you, because T3A means that it's gone outside.
Yeah,
Okay,
that was from before the PSMA, what he thought it would be.
so you would be restaged, and you're probably a T2B. How many cores did you have?
How many what?
How many positive cores?
All of them.
And how many cores were there altogether?
12.
Okay, so I'm pretty certain that's a T2B. I'd have to just look. I don't think T2C is a category of, I'm trying to remember. I haven't done this for a while. And then you put in how many positive cores. If you're 12 out of 12, you put that in, and then you are going to press you're going to press the score, and it's going to tell you the likelihood that surgery alone will be sufficient for you. So hold on a minute. T2, you could be, if the cancer is in both sides of the prostate, the stage is T2C. So you're a T2C. Okay. And then you press, and it's going to give you a percentage. That percentage is probably going to be very low. And then
Okay.
you have to make the call. Do you want to roll the dice? Well, first of all, you have to say, do I believe this? So as Len says, it's not as good with high Gleasons, but that's exactly the time, I think, when you need it. This is what I used, but I was an 8. And this is what I used to make a decision whether to do surgery or radiation. I mean, my feeling is if it's not that good, it's because they don't have that many people doing surgery with a Gleason in Gleason 9s and Gleason 10s. But that tells you something.
Right.
And this, by the way, I've not found a better nomogram than this one. I think this is the best one that's out there. I mean, Hopkins has one, UCSF has one. I don't know if Dana-Farber has one, but I think this is a pretty good one. And this is going to tell you the percentage, and then you're going to have to say, yeah, I'll roll the dice and I'll go through the surgery. But knowing that there's a huge chance that
I'll be
it
back.
might work.
So
what's the number?
Well, I mean,
you just did it, didn't you? What's the number?
I did not do it. Well, my attention span's not that good to listen and
Okay.
talk. It was good enough to like find the place to click, but not to read more.
Okay. I thought you did it when you said yo. I thought you had
No,
it.
my urologist said, obviously the chances are not as good, as it would have been with a lower Gleason score. He said, there's a chance. It's not as bad as he originally thought, but there's a good chance that it could take care of it. But he said the reality is there's also a good chance it won't, and you'll need some other treatment afterwards.
So
Okay.
Bob, I mean, is there a chance you can get some other scans before you do plan surgery?
Like what? I mean, I've had bone scan, CT scan, PSMA.
And they show nothing.
The CT scan had shown 1 or 2 lymph nodes, I believe, that were flagged but not indeterminate. And that was one of the reasons to do the PSMA. And the PSMA did not indicate anything for those lymph nodes. They indicated that they were not highlighted. I don't know the right terminology.
So the PSMA saw nothing outside the prostate.
Correct.
Yeah, then it's a tough choice.
Well, I look at it and, all the choices suck. They just suck less than doing nothing.
And making the choice is agonizing, if I remember.
Yep. So I can kind of speak to it because I went in as a 4 + 3 7, and I just wanted the damn thing out and be done with it. And surgery went really well. I was pretty happy. Fairly dry, just a little stress incontinence, and I can get an erection. But damn if it isn't coming back, and I'm on my way to radiation. And I ended up a 9 coming out of surgery, a 4 + 5. If I had to do over again, I'd probably just do the radiation, be done with it. That'd be my choice now, but don't get to
Me
make
too.
that choice again.
Yeah, I
So,
want to say something here if I can. Robert, I was only, I say only, so there's no only about it. I was 4 + 3, but I had, and I knew how many positive cores I had, and what I didn't have is any PSMA-PET because it was 2019, wasn't available to me. But the post-op, I had a seminal vesicle invasion and a positive lymph node that they could not have known the biopsy. They decided to tell me, even with undetectable PSA after surgery, that they wanted to throw a bunch of stuff at it. And I didn't hesitate to take it. But I don't know why I'm telling you this, except that certainly if you're a 9, even though you don't see it out there, I think these guys are, they're telling you something that you need to take heed. And that surgery and radiation are reported to have equal efficacy. But of course, surgery doesn't have equal efficacy if you have to have radiation later. And this is the major complaint that guys have with surgery. And I can tell you from my experience too, that surgery is no day at the beach in a number of ways that we don't need to talk about, but probably know what they are.
so
Yeah, I've
let,
kind of gone through the list of things. So
Rob, let me just say, first of all, I just ran this for you. I think I got all your numbers. I used a 12.8 PSA, and you said you were 12 positive cores out of 12. Is that right?
yes.
So the result says that the likelihood of organ-confined disease is 4%. Extracapillary extension is 96%. Lymph node involvement is 73%, and seminal vesicle invasion is 83%. Now, that said, you said you did a PSMA, right?
Yes.
And
Just like within the past 2 weeks.
right. And which PSMA was it? Pylarify?
Yep. Polarify was in the words that they used about it, yes.
So if they use Pylarify, I definitely ask for a second reading on that Pylarify, which is easy to do, and I can send you the link. Your doctor has to request it. I'll send you the link. You can't request it, but he can request it, and either I'll put it in the chat window if I can distract myself. I still owe Alan something. I haven't gotten there yet, but I'll put it in. I'll put it in for you. I get it reread. Secondly, there may not be any lymph node involvement, but I don't know how good PSMA tests are in identifying what's going on in the gland, and to what extent a PSMA test is going to show you if there's extracapsular extension. And the reason for that is because the way that the PSMA is located on the body is very sketchy. They have to get, we were talking about it before, they have to get a CT scan so that they can locate the PSMA on your body, because there's no physical characteristics on the PSMA scan that allows a doctor to know where these lesions are. So they have to then do an overlay onto the CT scan. So since it's not that,
Actually, the urologist was doing that in real time when I was talking to him. He's looking at the CT scan and the PSMA scan,
Right.
to look for the lymph nodes.
So the lymph nodes are fine, but the question is, what about the gland where it's maybe even finer, where you're trying to see if it's gone through the wall?
Oh, okay.
You see, so this is also why, and again, I don't know. Well, this is Maroney, wasn't that who you were seeing?
Yes, Dr. Maroney, UC Health.
So again, you got to ask him how many PSMA scans have you read, and we got to get it, because this is the experience from MSKCC. They expect 96% of the time there's extracapsular extension. If they find extracapsular extension when they take out your gland, then the likelihood is you're going to be facing radiation. Now, you may not have lymph node involvement, but you may have seminal vesicle invasion. 5+4 seminal vesicle invasion, you're looking at radiation plus at least 18 to 30 months of hormone therapy. Now, if we can save you the surgery, then that's significant.
Can I ask a question, Rick?
Go ahead.
So have you had a second opinion?
Dr. Maroney was the second opinion.
And who was
First
the first
opinion
opinion?
said, well, this is just garden variety prostate cancer. I can remove the prostate, no problem.
And Maroney is another urologist?
Yes, and I've talked.
And he's also recommending surgery.
Well, he originally didn't, because he before the PSMA, he said it's extremely highly likely that it's already gone beyond the prostate, and his original comment was surgery is not really a good option. He said you probably have less than a 5%, maybe less than a 2% of it being successful.
No, it's 4%.
And he was recommending radiation with hormone.
So is there a chance you can get a consultation with a good radiation oncologist for their opinion?
I have an appointment with a radiation oncologist scheduled for Monday.
Are they a prostate specialist?
I believe he's a prostate specialist. That's one of the things he focuses on. He's the only one in Colorado that I found that actually uses the word prostate in his profile. He has a prostate coordinator on staff.
Okay, so it seems to me that I think that you're on the right track. Before you go for surgery, talk to the radiation oncologist and see what they think, because that's the other option.
Okay. Well, I've been kind of going through this since June. Everything seems to always take an extra several weeks or months to get scheduled, and keep kind of like trying to get something done about it. And I've been trying to get all the tests. It's been a very frustrating experience having insurance deny everything, most everything, every step of the way, and then have to go resubmit and appeal. But okay, that makes sense. So I should keep the appointment with the radiation oncologist and probably reschedule the surgery, or delay it for the time being.
I mean, I think it will save you, and in the end, you're going to make a decision based on more informed data.
Yeah. I mean, part of the thing that scares me on the radiation is and the hormone stuff is, some of the impacts I've been told about, which it can impact cardiovascular, which I have a family history of heart disease.
Yeah,
that kind of concerns me.
Yeah, the problem, Rob, is that you're looking. It's highly likely you're looking at it either way. You're going to do the surgery and roll the dice, and the likelihood that you won't need hormone therapy is certainly less than 10%, and maybe even less than 5%.
So we will. Oh, sorry, Rick.
And so you could be the lucky 5%. You could win the jackpot and it could be fine. But if you don't, then you're facing the hormones, you're facing the hormone therapy, even with the radiation. Go ahead, Dr. John.
I was just going to say that if it comes to that, we'll show you all the different ways that we found to mitigate those particular side effects for radiation and hormones.
Okay. Yeah. Well, I guess I was hoping the odds were more like, 40%. I'm thinking, oh, those are odds I'd swing for. But,
Right.
Odds at 5%, probably not.
But Rob, that's exactly why we encourage you to do the nomogram and discuss that nomogram with your urologist. When I walked into my urologist after my biopsy to discuss where we were going, he handed me the MSKCC nomogram. That was back in 2007. And he said to me, this is it. He says, I'll do the surgery for you, but you've only got a 30% chance of coming out with that. So you got to decide. And yours is less. And I'm just sending it to you. I've downloaded it and I'll send you the readout. You can run it again yourself, but I just downloaded it and I'm sending it to you right now. So you'll have that. And you can print it out. You can take it to Maroney and see what he says. Now, obviously, he's going to say, well, the PSMA scan is saying you don't have lymph node involvement. Great, but I don't know. I just don't know whether it's going to be precise enough to know whether you've got extracapular extension, whether you can see it in the SVI, because presumably the gland shows up as a big blob.
Yes, probably. It
so
did show up in the prostate, yes.
So it shows up in the prostate, but it's sort of, there's so much of it that
And he said the high Gleason is on one side.
Say that again?
The higher Gleason numbers are all on one
side. I mean, I suppose they could do, guys, help me, Dr. John or somebody. I mean, they could do an MRI to see if there's extracapsular extension, could they not?
Yeah, it's commonly done before even the biopsy. But yes, they could.
They did. I had an MRI done on prostate. I don't recall any more details other than it seemed to confirm that, it's throughout the prostate.
My seminal vesicle invasion was picked up on a color Doppler ultrasound.
Yeah. Sometimes. And did you have an MRI too, Peter?
No, this is before MRIs.
Yeah. So.
I think we need to take this offline, Rick, and we still have a bunch of guys we have to get to here.
Go ahead, fine.
Carl, you are patiently waiting there. Go ahead.
Okay. I've had some recent vision issues, some blurriness, not having been able to drive as much at night as I used to. Went to an optometrist a couple of weeks ago. She did all kinds of tests and she said, well, you have cataracts. So she recommended that I go to an eye surgeon. I went to the eye surgeon earlier today and we talked about the treatments I've been having. And he specifically said to me, have you had any steroid treatments? And I said, yes. And he said, well, that is a contributing factor to cause cataracts. So I just wanted to bring that out to the group here, if anybody has had such an experience with the more longer term use of steroids, whether it's prednisone or dexamethasone, etc.
Carl, are you aging?
That?
Are you aging? Is you,
No, well,
and I
obviously,
wrote,
I mean, obviously,
that
it's
is a
clear as we
major,
age, we're more
that is a
susceptible.
major contributor to cataract formation. Probably even
Thank you,
more than
Mr.
steroids.
Obvious. Thank you, Mr. Obvious. Okay, anybody else have anything to contribute to?
Carl, have you had any high dose steroids or just the prednisone from abiraterone or something like that, or what they give you with chemo?
Yeah, no, I've had it for over the past 4 years on a regular basis. I take it every day. So.
Every day for what purpose?
The prednisone. Well, I had prednisone. Now I'm on dexamethasone. Was switched over, but that's what my oncologist has me on. So.
I have cataracts that are very mild and have not changed in the last 2 years, even though I've been on abiraterone for 4, and so prednisone. I was told by the optometrist I went to at Kaiser that almost everybody my age has them, so it's not uncommon as you get older, as people were saying. But if at my age, 75, it's very common. Almost everybody has at least minor case.
But mine are pretty large, as I said. It's a 5 out of 5 in both eyes. So
it's a pretty straightforward surgery.
Right, the surgery is pretty easy.
right. I will probably have it done sometime in December, I think is the earliest available. He did say he would coordinate with the oncologist if there was any, potential interaction that had to be taken into consideration. So that's my story. Thank you.
All right, Carl, thank you for the heads up on that. Something for guys to consider, I suppose. But of course, you can never really tease it out and know what's causing the cataracts. As Herb says, you're aging, or did the steroids contribute? We'll never know. All right, let's see. Herb.
No, I gave my report at the beginning.
Okay.
Just that my PSA seems to be responding to Pluvicto, and so is, but I didn't say that my dry mouth is getting worse. And Bob, thanks for all your advice as to what to do about it.
And what are you doing about it?
Well, I'm sucking on this stuff, and I'm flossing at night and making sure that I won't get cavities. The response from, this is in advice from Bob.
All right, and you're having any difficulty eating, chewing, swallowing?
No, not yet, but I bet you it's coming. I bet you after my next Pluvicto it's coming, but I'll let you know then.
Okay. Well, hopefully that will never develop. Okay, who else have we got? Kurt Shipper?
Chopper. Let's see, just a follow-up. So I was on 2 weeks ago, got the recommendation to see Dr. Antonarkis. I can never pronounce his name. At University of Minnesota. I actually got an appointment with him in 5 days, so that was kind of amazing. Saw him, and he basically concurred with everything that I'm getting, and the path that I've taken. So that was encouraging. He specifically, I asked him about 6-month Eligard versus 4-month Eligard, and he said that for someone who's 65 plus, the 6-month Eligard is totally appropriate, and didn't say anything about, wasn't worried about a 2-month fall off. The last 2-month efficacy of the Eligard. So he's happy with the path I'm on. That makes me happy with the path I'm on, and we'll see again in whatever, 5 months when I made a follow-up appointment with him in March 23 to just kind of see where I'm at after 6 months after end of radiation treatment. At that point, I think I'll have to make a decision about who I'm using as my primary doc, if it's going to be Kwon in Mayo or Antonanarchus and at Fairview in Minneapolis. So
What did he
it.
say about genetic and genomic testing, Kurt?
Oh yeah, I'm sorry. I'm getting the getting the both genetic and somatic testing, or somatic testing, so he ordered the somatic testing from the samples at Mayo, and I just, in fact, today shipped off the in vitae germline testing. So we'll see in maybe a month and a half or so, whenever that comes in.
No, I mean somatic testing shouldn't take more than a couple of weeks,
right?
And the invitae should be. The one thing I would suggest to you is we've just seen guys have problems with these 6-month shots.
Mm-hmm.
So just to be careful, in the 5th and the 6th months, you might want to get your testosterone checked. Just get your
his point was that for guys that are 65 plus, and I'm 68, that your testosterone's not going to rise very fast after you stop ADT anyway. So anyway, I think that.
Yeah, but he's right. I mean, we can't argue, but we've seen it. We have seen it happen in guys in their 60s. So, for the sake of a testosterone test, if you do want to get that 6-month shot, just to be conservative, just get a testosterone measurement in the 5th and the 6th month, just to be sure.
Sure. Okay.
And you can also request 24 instead of 26 weeks. That's what I did. Get a couple more weeks of just hedge a little bit.
24 for the Eligard?
Yeah, get your next shot at 24 weeks instead of 6 months.
Okay.
Yeah, I mean, you should be doing blood work every 3 months anyway.
Yeah.
Right. Yeah, and I will be.
All right.
How did you like Dr. Antonanarchus?
I liked him. He seemed very, very approachable. He and Kwon and Davis, they all hang out together. So that's hang out, collaborate. So he was happy with the team that I have. So I'm happy with the team I have. So.
Okay, thank you. John Madden, you want a little time tonight, right?
Yes, please. Yeah, I started, I was able to start chemo at MD Anderson. My doctor said, you know what, by now you've done your research, you know what you're after. I'll go along with you if you want to do chemo, and I definitely did. And it's not as much fun as it sounds like, and I'm having a little bit of trouble with my the insides of my cheeks are a little bit burned, and I don't imagine they're going to heal anytime soon. And I'm using baking soda and water to chase away the acidity, to keep my mouth as clean as possible without getting it rashed up with a toothbrush. Is that the best approach? Is there any better recommendations than that?
Yeah, John, I would, can you hear me?
Yes.
I would suggest ask your doctor or even your dentist where it's called Magic Mouthwash, and it has to be made by the pharmacy. It's a combination of, it's 1 part liquid lidocaine, 2 parts liquid Benadryl, and 3 parts. Usually they use like milk of magnesia or something like that. So it kind of numbs it. The Benadryl helps, and the milk of magnesia just forms a coating. You swish with that, and you swallow a little, and that's going to work better than salt water for what you
Okay.
got. Also, you want to check your tongue and make sure you're not getting thrush. Uh, every time I got chemo, I got thrush on my tongue,
All right.
and that would look like a white film, and sometimes that can get onto the back of the throat and even into the cheeks.
Yeah, that might be happening. Okay.
Yeah.
And
For
then
that, you need a nystatin liquid if that's happening, and that can
nice.
give you a burning feeling and a dry mouth feeling too.
Okay. Yeah, it is doing that, and I can't even lay on my cheeks and on the pillow. And then second question is
Hold on the first question. I'm just putting a link in the window for you. There was an article in Conquer magazine, I mentioned it before, on treating oral pain from cancer. It's a pretty basic article, but you might find it helpful. I think it sort of mentions the magic mouthwash, and I just put it in the chat window so you can click on that link. You can read it later.
thank you. Great. Yeah, this is really good input. Thanks, guys. Second one, my white blood cells were a little low coming into this, and I don't know. I guess my neutrophil absolute was a 1.56. It's supposed to be, I guess, in a range between 1.7 and 7. And is that a big concern? Or should I be asking for something to boost the white blood cells? Or
I can maybe take that question. 1.56 is marginal, but it's not enough to make you sick or put you at risk. If it stays in that range, just don't worry about it.
okay,
If it keeps going lower, then your doc has to find the cause and do something about it. Yeah. It's not like red cells where there's a pill you can take to boost your white cells. You just have to remove the cause.
okay,
With
okay.
with chemo, usually they give you Neulasta. They're not doing that?
Not yet, and that's what I was new last. Okay, I'll ask about that if I guess if there's any change to the negative, I'll
It's pretty standard. They put this patch on, it automatically injects the day after your chemo treatment.
okay.
Almost everybody gets it.
Yeah, there are also bioequivalents. In fact, I just self-injected 2 minutes before this meeting started with Extenzo, which happened to be the one that my insurance company would cover. But my first chemo, I didn't have that, and my neutrophils got down to 0.1. Fortunately, I didn't get sick, but that's about as low as you can get. But if you're just a little low at 1 week, that's not too bad.
Okay. All right. And then the last question might not be an easy question, but I guess as this gets worse and I might need to take some prednisone, how do you? I mean, this is kind of like trying to take a PSMA when you're on ADT. How does anybody keep track of the tumors that I have in my lymph nodes or whatever? If I'm taking prednisone, everything's probably going to get reduced in size and the swelling will come down. The PSA is supposed to go in half when you're on prednisone. And the reason I bring this up is because I had like a baseline scan, and it was a CT scan to see to get a before picture before chemo, and I'm a little bit allergic to the iodine, so they gave me a bunch of prednisone going into it. And radiologist that did the write-up said there's nothing to see here. Pretty much everything that showed up on the PSMA had shrunken down so small that he didn't look at the PSMA, the original scan, so he didn't know what he was looking for or where things were. But it had shrunken down on that CT scan so much that in his write-up he wrote that there was nothing to see. And that day I was on 100 milligrams of prednisone. How do we keep track of growth if prednisone is going to make everything shrink like that? It's similar to the same question with how do we keep track of growth with the PSMA scan when ADT gets in the way of PSMA?
Who wants to take this one?
I'm not aware that glucocorticoids by themselves would shrink cancer lesions. I mean, they're anti-inflammatories. I'm not sure. Maybe I'm not understanding the question. Is that your concern? You think that just because you're on prednisone or whatever it is, that it's falsely limiting your PSA?
I think it. I found an NIH article that said that it can reduce your PSA up to 50%, and what if you take enough prednisone? And I'll share that link. I'm pretty sure I saved it, and I know from past experience with sinus polyps and some other things that swelling of anything just goes to nothing when you take enough prednisone. And in their protocol to prepare me for that scan, they wanted me to take 3 50 milligram prednisone pills. I was only able to get 2 in, so I was only on 100 milligrams of prednisone for that scan, and everything had reduced in size so much that the radiologist said, you know, there's no evidence of you know, any kind of problems with the lymph nodes.
And they're giving you the iodine. Is that for contrast?
Yes.
Maybe they should do the scan without contrast. Ask if that's possible. You won't have to take the high dose prednisone.
Yeah. Okay. I was thinking that maybe I could try to talk them into letting me just do Benadryl on that day instead of the prednisone. But yes, scanning without the iodine, without the contrast, might be the answer.
Yeah, I've never come across this issue before. I mean, and neither steroids causing having an impact on PSA. This is a totally new one for me.
Yeah.
Herb?
No, I would love to have that citation to the paper so that I can read it, but I'm doing a scan right now and have not found anything.
Okay, I'll send that link, and I mean, this is, here, let's see, I'm going to share my screen real quick. This is, I think I'm going to share my screen. It looks like I'm not going to share my screen. Yeah, my PSMA scan, it looked, I mean, I had, my lymph nodes were all over the place on that. And on this CT scan, the radiologist literally wrote nothing other than a little lump in my lung, which is not even part of the PSMA. He said there's nothing to see. Now the doctor went in and looked at it, looked at the scan, and he found, yeah, there's still definitely some swelling here on some of these lymph nodes, but it wasn't anything that jumped out at the radiologist that was doing the initial interpretation.
Hey, John, I just made you a presenter. Maybe now you could share your screen.
I'm finding I have to use I have to go into my preferences and allow it. Here it goes.
John, this is Jim Marshall. I found the same reference about 2 years ago, but I did not stick down exactly the place I found it, and it explains it exactly as you said.
Yeah, it's yeah, up to 50% on the PSA if with enough prednisone. I can't remember I'll try to get that posted. But here's, let's see, let me share my screen. Here is share. This is where all of my PSMA metastatic sites were. And I've only taken Lupron. And this guy is writing in the CT scan that nothing to see. No lymph nodes. And I just think it's awkward. I mean, I don't know how do I turn off sharing? I'm trying to turn off sharing now. Okay, there, sorry. I'll find that article. Impact of, no. Oh, this wasn't.
I mean, it seems to me that John, do you still have a prostate gland? I can't remember.
Yes.
Okay, so it seems to me that if you have inflammation in the prostate gland, then yes, I could definitely see it affecting your PSA if you took, because the steroid is going to reduce the inflammation in the gland. But if you don't have, I mean, I don't know that cancer is going to cause that same level of inflammation that, say, an infection would.
Okay, I just found the paper that says prednisone. It's by Kim Chi.
Oh, I know who that is. Yeah.
And it's for people with castration-resistant prostate cancer, not for your stage.
Okay.
So, and basically, they said there was a 22% response to prednisone as defined by a 50% PSA decline.
John, didn't they give it to you the day of? I mean, that's when we had people that were allergic, that we gave it to them the day of, right?
They had me take one 50 milligram the night before, and then one the morning of, and I was supposed to take one an hour before the scan, but they rushed me through and they told me to show up early, and then they made me wait an hour and rushed me through, and it was I guess they were having a bad day that day.
I don't see where that much steroid would do that in a day, right? Anybody else? I mean, what? Not that fast acting, is it, Len?
You got me, Norm. This is new to me.
Yeah.
But in any case, someone, Dr. John, I think someone said, when you stop the prednisone, the effects will pretty quickly diminish, and so you'll see where your PSA really is. I wouldn't worry about it.
Okay.
Maybe you should be happy. Is his ADT working okay?
Is that possible? To work that well?
I don't know. It's a question. I mean, I can't see where the prednisone would do it, but I could see where the ADT might.
Okay.
Ask these experts. You ever see
So-
it work that fast?
So there's another paper here that I just found, but where Sartor is the lead editor, where he says that if you're castrate resistant, 10 milligrams orally 2 times a day of prednisone, that's 20 milligrams a day, can reduce PSA by more than 50% in a third of patients. But I mean, I'm not sure where this is concerning you, John, in the sense that you're not on a regular dose of prednisone.
No, I'm not. But you know, if I were to go the Zytiga route, I would be. And
But even if you went the Zytiga route, you might not be getting 10 milligrams. You might only be getting 5 milligrams, 2 by 2.5. You know, I think, again, there's so many ifs, ands, or buts. Stay in the present, man. You're going to make yourself nuts.
okay.
You're not there. I
Yeah.
mean, you're not on regular. I mean, I was surprised to hear that Carl Foreman was getting regular prednisone. I mean, now I see where this is coming from. We rarely hear about men being on prednisone as a regular as a standard of course treatment. But I guess they could be. But I mean, here they're talking about 20 milligrams a day, and for prostate cancer, even with abiraterone, you're talking either 5 or 10 max,
Rick,
2 by 5 or 2 by 2.5.
Rick, that paper you put on was from 1998, before before anything modern has come along.
There you go. You know, I mean, everybody's going to find, if you go look hard enough, you'll find something as to make yourself crazy about.
Okay.
And you're
Well,
doing yourself more harm than good. Where's David Muslin? Did he leave already? Stay in the moment. I think he's left.
Sorry for the can of worms on that one.
All right, guys, got to close you down because the multiple sclerosis people are coming in 8 minutes. And any second now, we're going to have them showing up in our meeting, and we have to stop we've got to stop the recording so we can close the room and reopen it.
You want me to stop it, Rick, or are you gonna?
We can just close the room.
Okay.
You can't fire me, I quit.
There you go.
I was waiting to hear a song from Jimmy. Good night.
Good night, everybody.